Welcome to Harlow on Healthcare. I'm David Harlow, and I invite you to join me by my virtual hearth as I sit down with healthcare leaders to discuss building the future of healthcare. Today, my guest is Andrew Altorfer, CEO of CirrusMD. Welcome, Andy, and thanks for joining us.
Thank you for having me.
So, Andy, for starters, I wonder if you could describe your product or service and tell us a little bit about who your customers are.
Sure. So we are the first text-focused telemedicine platform in the industry. We originated out of my co-founder Blake's vision of how his friends and family connect with him. Blake is an ER doctor, and after he got out of residency practicing medicine, he began to realize that whenever his friends and family had a clinical concern, they would simply send him a text message. And he found that to be a very effective way to walk through a diagnostic process and to assist the people that he cares about. And when we met, he was starting to think about how do we extend that relational experience that the friends and family of doctors have today to the broader market. We have found our home working in the health insurance market. We are currently working with 5 of the 10 largest payers in the country. It is about creating better efficiency, increasing access to care, and helping patients better navigate themselves through the healthcare system. We have had exceptional results with that. User satisfaction is incredible. The doctors find it to be a very pleasing experience to deliver more care to more people. And we're really excited about the progress we've made over the past 7 years.
So the platform is available to the doctors who are in the payers' networks, or are you using your own cohort of physicians?
It depends. We have our own 50-state physician network with over 200 doctors in it. It's a full multi-specialty practice ranging from generalists like primary care doctors and ER doctors into a variety of specialty care and also a variety of non-clinical resources and things also like pharmacy, behavioral health as well. So it's a fairly extensive network for the pure play payers who do not have existing physician networks. That is generally how we are deploying ourselves. For integrated delivery networks, we work with the largest one in the country. We also work with the VA who have existing clinical resources. We allow them to use their own physicians as well. So it somewhat depends on the customer, and there are a variety of ways that we can deliver staffing.
Okay. And if you're dealing with a customer that has their own physician network, does that change the way in which the protocol for care is structured or the way care is delivered? Is it more up to the individual provider network, which I guess in some cases you and in some cases is somebody else?
We work really closely with the customers that are provisioning care on their own to ensure that the same clinical protocols and standards are being met. We operate in a very consultative manner where we are working with them on their clinical playbooks, where we are working with them on medical direction. So the consistency of care, regardless of if it's our own provider network or customers, is fairly standard.
Okay. So let me ask you a pain in the neck question. Aren't some sorts of encounters really better if they're face-to-face or at least visual versus text-based? And do those get screened out, or do people end up having 2 encounters, one through your system and then one with, as a live encounter with somebody else?
No, it's not a pain in the neck question at all. It's very valid. We work with our physicians and other providers on the platform to make sure that they are delivering to an appropriate standard of care. And doctors are really good at being able to assess and understand what information that they can get and what information that they need to make a decision. And in many cases, a decision may end up as a care plan. Over 83% of our encounters are completely resolved on the platform as understood through claims data analysis, working with our customers to measure downstream further encounters if somebody we say is resolved and then shows up in a brick and mortar for the same condition a day later. That doesn't count, and that happens very, very rarely. That said, some percentage, about 17% of patients do need to be sent in, but we're ensuring that they're sent in with a care plan to the most appropriate point of care, which is very rarely the emergency department, where most cost in healthcare tends to come from.
Right.
And so there is value even for the member who does get referred in. That said, fewer than 5% of encounters on our platform need a quote unquote face-to-face visit, meaning a video consultation. While all of our encounters begin and end with a text conversation, we can engage in video chat, we can engage in a phone conversation, but it's very rare that that's necessary. The doctors are able to glean a significant amount of information through a text conversation with the patient. Things that do tend to end up on video chat are generally pediatric respiratory concerns. A mom coming in saying, my baby is not breathing right. Doctor wants to get that on video. Certain neurological issues. Again, I want to get a look at you to understand what I'm dealing with here. Outside of those couple of use cases, the doctors, and with the ability to share images as well. Hey, I've got a cut. I've got a rash. Something doesn't look quite right. My pallor is not quite right. That can be done through image sharing. And our experience is very different than video-focused telemedicine, where you go have a 5 or a 7 minute video conference with a doctor. It's text-driven. If the doctor wants to get you on video at their own discretion, they can. Again, that's very rare, but it allows that dynamic to take place if the doctor needs that information, and the doctor can do that at their own discretion. Does that make sense?
It does. That's great. So it sounds like in a minority of cases, those other modalities are available, but it mostly ends up being text only.
That's correct.
And are these rapid fire text conversations? Are these consistent with sort of a 5 or 10 minute live video telemedicine visit? Or do they sort of stretch out longer the way my texting conversations go with my kids?
Well, that's the beauty of having a asynchronous text-driven conversation. For the first time, we've put the pace of the conversation in the patient's hands. Mm-hmm. The doctors are serving at the behest of the patient. We love, and we get this feedback regularly, where a patient disappears and the doctor follows up. Hey, I never got a response from you. 30 minutes later, the patient comes back. Oh, I'm sorry, I was in a meeting at work. I'm ready to talk again. And that ability to disengage and re-engage is completely unique to text. When you think about an employee in an office space trying to do a video chat with a doctor, there's no privacy. And that is not what occurs on our platform. The patient can engage with the doctor from anywhere at any time with the ability to protect themselves from whatever's going on around them. Our average encounter length is actually more than 40 minutes. That doesn't mean that the patient and doctor are constantly typing for those 40 minutes with one another. It's that asynchronous nature that can be dictated at the pace of how people typically communicate, like you referenced with your children. We have mimicked how people communicate in the real world and developed a set of clinical protocols and management tools around how communication is done today, but in a way that is safe and scalable for clinical medicine.
So you talk about scalability and you talk about payers and other organizations that you're working with. Are you able to give us a sense of the volume of calls that you're seeing these days?
Yeah. I mean, on our average weekday, we're seeing more than 1,000 patients a day. Volumes on the weekend are about half that. And on a week-by-week basis, we continue to see more and more patients. So in total, we're approaching about 500,000 visits that have been completed on our platform. And that number continues to grow very, very rapidly.
And do you see a cohort of frequent flyers, or is this pretty spread out, occasional use by different folks who have access to the service?
Yeah, the average engaged user sees us 2.5 times a year. So while there certainly are specific frequent flyers, we and our customers have done studies around them. And there are people who, instead of showing up at the emergency department 10 times a month, are now visiting our platform. So we actually are even impacting total cost of care for the frequent flyer population, but that's a very, very minimal percentage. Your median user of our platform is seeing us just over 2 times a year. Interestingly, within Medicaid, where we do a lot of work, your average Medicaid user comes on about 5 times a year. And that is directly correlated with lack of access to care. People on Medicaid plans don't have as many options. And so it's interesting to see that the engagement rate is about twice as high in that population.
I see. And I expect you'd be able to point to increased savings there as a result as well.
Absolutely. I mean, so many people on Medicaid don't have access to primary care doctors. They don't necessarily have the ability to cash pay at an urgent care. And so the average person on Medicaid oftentimes only has the emergency department, which costs over 10x what an urgent care visit does to the broader system, as their only option for care. And that's currently how the system's structured. And by providing this into populations that don't have good care options, we're seeing incredible results.
If you're just tuning in, this is Harlow on Healthcare, coming to you on Healthcare Now Radio. I'm David Harlow, and my guest today is Andrew Altorfer, CEO of CirrusMD. Andy, you mentioned that you're working with the VA, and I just have to ask, how is working with the VA different from working with anybody else?
Yeah, we love it. I mean, my belief is that true integrated delivery, where the entity that has financial responsibility for your care, the insurance company, the VA, whatever integrated delivery network you might have access to, who is also provisioning care, is an ideal structure. And we really, really like that because they have referral patterns. They have access points, both brick and mortar and virtual. And we believe that we can serve as a very effective front door to help navigate patients through the system. We're a veteran-founded company. My co-founder, Blake, was in the Marine Corps. We have a number of other veterans in our senior management team. Veterans are incredibly important to who we are and who we want to serve. So we are very, very excited to be partnering with them through Iron Bow Technologies, who we're a subcontractor to. But we have a lot of heart in our organization for the veteran population. In terms of how it works, the VA works just like Kaiser, for example, does on our platform. They have their own clinicians. They have a variety of types of providers that they're making accessible to their member population. And we work with them to raise awareness in the member population that this is an available service, and then to develop clinical protocols. So treating members of the VA isn't necessarily any different than any of the other insured populations. It's just something that we really care about as an organization.
As you describe, it sounds like you appreciate the ability to work with an integrated delivery system, also in this case integrated with the payer function, to be able to have a more holistic view of the patient.
That's correct.
Yeah. Now, as you describe interacting with provider organizations, payer organizations, I'm wondering how you see your service being integrated with other services and the records of these encounters being integrated with other encounters. You talk about a plan of care and care coordination. How does that work in practice? I mean, adding another modality of care, particularly something that's a little bit different like this, text-based, may present challenges in terms of being able to offer coordinated care to the patient and a full view of what's going on to the primary care provider.
Absolutely. I mean, we are, first of all, text is a great modality for delivering care because it's self-documenting. We have a very unique view into how patients communicate about their health. When you think about what gets captured in the electronic health record, it is synthesized by a doctor. It's not actually the non-specific complaint that the patient presents with. It is the post-synthesis after engagement over some period of time between a patient and a doctor that ends up in the record. We actually have a direct understanding of how patients are presenting in a way that's never been captured before. And through progress notes, which is effectively our SOAP note that captures a variety of analytics, recaps the encounter, that's directly integratable into whatever the primary medical record is, whatever health information exchange might exist in a given region. We have a high degree of flexibility depending on who the customer is and what other data resources are available to pull in data, pull in demographic information, and then output encounter recaps into whatever system resources are available. So that's highly configurable. Ultimately, we want as much data transparency as is possible. Unfortunately, healthcare is not at a point where that is in an ideal state everywhere. Some places are better.
I was going to say, you and who else?
That's exactly right. I mean, to a degree, we're a bit of a captive to whatever systems are available. But whenever possible, we're doing EHR, EMR integration, pushing information to health information exchanges. There's a really good one here in Colorado, for example, where your primary care doctor actually is notified every time you have a virtual visit with a full encounter recap. That's an ideal scenario. Unfortunately, that doesn't exist nationwide.
Right. The future is not evenly distributed.
Exactly. So we're doing the best that we can wherever it's possible because we fundamentally do believe that this does need to be a very integrated experience. And when we talk about working in the scenario of integrated delivery, that's ideal because there are common medical records. There is the ability to ping the PCP whenever a visit occurs. And so that's where in our early days, we've seen the most success over the past several years because that data continuity and throughput is there. That said, we're exploring a lot of ways of how do we do that in the pure play payer market for the Uniteds, the Aetnas, the Humanas of the world that aren't necessarily fully integrated. How do we replicate that as much as possible? Because what we're starting to see is the payers who aren't integrated are wanting to own more and more of the patient's care journey. Fee-for-service medicine, unfortunately, has created a misalignment of incentives between the providers and the payers. The health system doesn't necessarily have any incentive to make your care journey more efficient, more cost-effective, or really produce better outcomes. And we're starting to see the big payers become very interested in how are we going to have better data continuity? How are we going to direct the member's care journey? How are we going to provide them with all of the right resources virtually in a very cohesive experience to get our members what they need to increase member satisfaction, to keep people healthier, and ultimately to lower total cost of care?
Right. So earlier you were giving me some figures about utilization of the service, and I'm wondering if you're able to tie that to enrolled patients' populations, or rather the population of patients who have the service accessible. What I'm thinking about is that over time, telemedicine services have been available to many, many patients through payer contracts or IDS contracts, and very, very few people actually have made use of these services. Do you see a greater uptake of the text-based service than folks have seen of the video-based services in the past?
We absolutely do. I mean, and that's a really funny early days story between my co-founder and I. My background's in engineering and finance. I'm the tech guy. My co-founder's an ER doctor. And I believed it was going to be all about video. And Blake's point of view was, I don't need that. Sometimes I do. In a very small percentage of cases, I do. But most of the time, I can communicate effectively just via text. And when we originally launched, we had the ability to either schedule a video visit or have an on-demand text conversation. Fewer than 1 in 1,000 people chose to do video chat. People just want to text. It's because it's how we all already communicate. And we have seen radically higher utilization numbers than traditional video-focused telemedicine. In the context of a payer, video chat is generally less than 0.5% utilization, meaning total encounters divided by total population with access.
Right.
Commercial populations, we are seeing between 15 and 30% utilization. Right out the gates, we are generally breaking 5% utilization, which are like the absolute best of the video and phone-based telemedicine services at maturity utilization levels.
Right.
We get there in a month. And it's how people communicate. And it's about how do we reduce as many barriers to access as possible to get people doing this. From a scale perspective, we have 4 million members with access currently, and that ought to double here heading into the new plan years starting in January. We have some cyclicality in our business that a lot of the big payers want to launch stuff on January 1 because it ties to their plan year. So we're growing quite rapidly, but as of right now, right around 4 million people have access to our services.
Well, the utilization rates are impressive. Thanks for that detail.
Thank you.
So far, all sounds great, but where have you seen the bumps in the road? Tell me about a frustrated patient or a frustrated doctor.
Sure. The biggest bump in the road in this kind of, when people ask who our competitors are, we're competing with legacy healthcare. When you think about a text conversation, it doesn't easily fit into the fee-for-service reimbursement paradigm. Can we pair ICD-10 codes to our outcomes? Absolutely, we do that. Can we package ourselves in ways that align with how people want to measure healthcare? Sure, we have to do that. But when we think about who we're really competing with, it's how do we change the paradigm of how healthcare operates? From a patient perspective, the frustrated patient either tends to be somebody who struggles to get registered. One of the big challenges in healthcare is that many of the large payers don't necessarily have particularly clean contact information for their own member population. Mm-hmm. That's a huge challenge that we struggle with. We have a lot of things that we do to address that. We have incredible customer service to help patients who are trying to register and for whatever reason their member ID is not lining up or something about their contact information doesn't match up with the authentication databases. So really clean data of who the member population is a big struggle. We have well over 95% satisfaction rates. So patients love our services and they say things like, I love my insurer. I will never switch insurance because this service exists. That's not something that the insurance market is used to hearing, which is where a lot of our opportunity lies. For the patients who do end up frustrated, they're oftentimes seeking a clinically inappropriate antibiotic. People will come on, they believe, hey, I've got this condition, I want an antibiotic. And we are very focused on lowering overall general antibiotic prescribing rates, which is a huge issue in healthcare today. When someone comes on thinking that they need an antibiotic and it's not clinically appropriate, those tend to be the most frustrated patients. But the doctors are using evidence-based medicine on when and how they do prescribe. And so in an actual clinical scenario, those tend to be really the only frustrated patients. And then the other frustration and friction point for patients tends to be that oftentimes the insurance companies don't have perfect data sets, which we are using then to authenticate whether somebody should or should not have access to our services.
Got it. Okay, Andy, lightning round question for you to finish up here. If you were to wake up tomorrow and find yourself 5 years in the future, what is one thing in healthcare that you would hope or expect to find has changed drastically?
I would hope that the opioid epidemic that we're currently facing will have vanished. That's not necessarily what our business is focused on. In the context of what we're doing, I believe you are going to see the payers move aggressively into provisioning more and more care services. And I referenced this earlier, but how do we more efficiently help a patient navigate themselves through the system, providing care virtually whenever possible, referring him into the best point of care when a brick and mortar visit is necessary, in a way that makes sense for the patient, in a way that saves cost to the system. And I do believe that we're going to see an entire wave of virtual first health plans begin to emerge that only engage the brick and mortar when it's necessary. And I think that's going to be the biggest change that we're going to see over the next 5 to 10 years. I don't know if it's necessarily 5 years. It might be closer to 10. But I do believe we're going to see that happen, and we would love to be a centerpiece to that transformation.
Well, thank you, Andy. I've enjoyed speaking with you.
Yeah, thank you for your time, and I'm happy to reconnect if you have any further questions.
Thank you. You have been listening to Harlow on Healthcare. Join us at healthcarenowradio.com. Let's continue the conversation on building the future of healthcare together at #HarlowOnHC. I'm David Harlow, keeping the fire going and holding a seat open for you. Until next time.